Well, if I start from the very beginning when I tried to work in lymphoma, was the classification of lymphoma. And for a while, there was a big competition between pathologists, and they did not want to agree on the name, on the size of the cell. And so what we did was to go back to our data and look at a large number of patients, 288, and classify them with an homogeneous way. And it was used for the WHO classification in 001. And from that time, it was possible to describe in a better way the different subtypes of lymphoma. So it was basically on morphology. And we could gather material and see what was the outcome of this patient. And of course, they were poor. And unfortunately, I would say that the prognosis is still poor at the present time. So because rituximab just appeared at that time, we had to change our mind and to elaborate study for T-cell lymphoma. So basically, we did the same than before, no very big news, and we looked at our data, and what we found was that 1/3 of these patients were refractory, half will relapse, and only 20% will survive for a long time, no matter what type of treatment you could do, except that you had some few situations where you can find a better prognosis for your patient, and that was the isolation of the anaplastic large cell lymphoma, especially the ALK2, and from Asia, the isolation of the NK T-cell nasal type, where it was possible with the treatment with radiotherapy and other chemotherapy to cure that type of patient. And especially, it was not necessary to use the standard treatment, the CHOP regimen, and just with L-asparaginase in combination, we could obtain a very high rate of complete remission. So from that time, the message was we have poor prognosis patient. What can we do at the present time? And so that was the progress of the technology which gave us some solution. We could not only look at the surface marker, you could look at the gene, you could look at the mutation, and so at that time we could target a little bit more our therapy. And of course, everybody is trying to do that. We are still trying to do that. Unfortunately, at the present time, if I want to give a summary of that, many drugs were tried and very few were very efficient. So that means that we need to work more, maybe on the biology of the disease, to work more on the combination of the treatment, and to try to adjust on the subtype, different type of approach. And in this meeting, what is important is to see how complex it is now, but we are more pathway to elaborate, and so we will have more target, I will think, for the next future to treat our patients and make significant progress. That's a good question. I don't think I can give you an answer because you have, like in physics or I don't know, in science, you have some axiomatic. So you have one group working on STAT3, STAT1, the wonderful talk of Dr. Weinman. Some other are more working on the immune checkpoint inhibitor. Some other are more working on other genes. So it's really difficult at the present time to say which one will be the most promising one. Maybe some combination, and we have to be very systematic in our approach and treatment, and not to just say, well, I have 5 patients, they are responding, that's a good drug, but to build prospective study with limited size to give a better understanding of the way the drug is working. Well, mostly in the last period or even in between, good prospective study to demonstrate more clearly the place of transplantation, for example, where we had quite a lot of signal that it could be effective in consolidation, but it's not clearly demonstrated. The other things that we missed was drugs. effective drug. We were very happy to have all this monoclonal antibody, and it started a long time ago with alemtuzumab. We expected a lot and it did not work, so we went to another one. Hopefully we have the brentuximab vedotin giving you good result in some subset of peripheral T-cell lymphoma. So we were more confused in the way we were running our study than we can be now with the biology, where we can at least collect the data from the very beginning and be ready when they relapse to have more targeted therapy and to develop them.